Bismillahirrahmanirrahim. Assalamu alaikum everyone. I hope you're all doing really good. The lecture that I'm going to deliver today is on mucolytics, expectorants, and antitussives. This is going to be your first lecture on respiratory pharmacology, and inshallah, in the next week, you'll be having 2 more lectures from this unit on bronchial asthma. So let's begin. Inshallah, by the end of this lecture, if you pay attention and if you listen attentively, you'll be able to identify various types of cough and the various management approaches that we use for management of different types of coughs. And then how do you classify various medicines that are used in cough? And the medicines that are primarily used to treat cough are mucolytics, expectorants, and antitussives. So by the end of this lecture, you should be able to differentiate between these, all these 3 drug groups. Although they are used often as synonyms, but actually there are very much distinct differences in their mode of actions as well as in their clinical indications. So you should be able to identify the differences between these drug groups, as well as you should be able to know their clinical indications. And of course, in this lecture, we'll be talking in detail about the mode of action and adverse effects of these commonly prescribed cough remedies or cough medicines. So let's begin. You might know that cough is a protective reflex, right? So when it is protective, it is protecting us from a lot of foreign particles and other irritant materials that just get into our respiratory airways. Remember that cough is not a disease, right? This is a symptom of disease. So cough is a protective reflex and it is actually a symptom, not a disease. So what do you think? Should we manage cough? Should we treat cough? Or should we actually stick to some guidelines or some management approaches to treat cough, because it is actually just a symptom, not a disease in itself? So in order to understand this concept better, first you should be able to identify the 2 main types of coughs, so that you can clearly differentiate and understand which types of coughs should be managed and should be suppressed and which shouldn't be suppressed. So the first type is the productive cough. And of course, the productive cough is going to be protective in nature because it is helping the person to cough out the extra secretions, respiratory secretions, the sputum, the exudates, and therefore it is helping the respiratory passages to get rid of that those secretions. So the productive cough is actually useful cough. And the other type of cough is the non-productive or the useless cough. And it is generally caused due to local irritation in any part of the respiratory passages, generally in the upper respiratory passages. And we might like to suppress this cough because it is not associated with the coughing out of any sputum or any secretions. So this doesn't look really protective in nature. So this type of cough could be or should be managed. So we'll be talking about it in the next slide as well. But before we talk about the management approaches in further detail, let's just have a quick look or just revise your physiology on the mechanism of cough. You might remember from your physiology that this is actually a reflex action, protective in nature. And as you can see, all the afferents and efferents and muscle responders are being mentioned here in a flow chart way, in a flow chart. But please make note that both the afferents as well as the efferent impulses are carried via the vagus nerve. Here is another way of looking at the cough reflex. It's just breaking down the components into receptors, afferents, cough centers, efferents, and the effector organs. So you can have a look at it as well. Moving on to this slide. This is a picture from your Katzen Pharmacology. And this is giving you a cross-sectional view of the mechanism of how our body or how our tracheobronchial tree responds to an inhaled irritant. And you can see that the inhaled irritant actually just initiates this cough reflex by sending afferent pulses through the vagus nerve, and it just reaches the cough center in the medulla oblongata. And from here, the vagal efferents, they are carried, the efferents or the efferent circuit is also carried by the vagal nerve fibers. And then when they reach the affected organs, which are in this case going to be your the musculature of the tracheobronchial tree, you can see that you can always correlate this with your knowledge of ANS pharmacology, that the neurotransmitter in such nerve endings, in preganglionic and postganglionic cholinergic nerve endings, was acetylcholine, and you can spot it here. This is acetylcholine, and via M3 receptors, it will cause smooth muscle contraction in the tracheobronchial tree, and of course, this is going to eventually lead to the act of cough will be exhibited. And there will be some more added host response in the form of mast cells and basophils recruitment in this area. Anyways, overall, you can just spot that this is a reflex action that in which the afferents and efferents are basically being carried by the vagal nerve fiber and the key mediated acetylcholine. And of course, the major effector organ in this case is the tracheobronchial tree. So when the muscles will contract, there is going to be coughing out of this inhaled irritant. So if this kind of reflex is protective, ideally we should not treat cough, and we should always look for the cause and treat the underlying cause. So what are the causes of cough? That brings us to this slide. You can see that the types of cough are clearly differentiated into two types: dry and productive, useful and useless. But in practice, the demarcation is not that distinct, as you can see laid down over here. But right now, for your third year level, I think this should suffice, and you should learn this. You don't have to learn it right now, but you should have an idea of the various types of coughs and the causes of cough, and you should just go through the slide in your free time. But for now, आप ये देख लें कि generally productive coughs are caused by infections, चाहे वो upper respiratory हो, lower respiratory हो, or like another important line here is that of postnasal drip, जो अपने शायद ENT में you might have seen or you might have read about it. Then there is COPD, which is chronic obstructive pulmonary disease, CCF, congestive cardiac failure, GERD is gastroesophageal reflux disease. So all these diseases generally lead to sputum production or excessive exudate production and productive cough. But allergies and asthma and exposure to dust and smoking, which is another way of exposing your lungs to some irritants, generally they all cause dry cough. So now that brings us to the management guidelines, or not guidelines, but the management approach for managing cough. As I've already told you that it is a protective reflex and it should not be suppressed, and you should always look for the cause, and you should always try to treat the underlying cause. So the basic principle is that the non-productive cough should be suppressed or could be suppressed, but the productive cough is protective in nature. If you suppress it, you are going to cause the secretions to stay back into the lungs, and when they'll stay there, of course, you can well imagine the consequences. So now, moving on. This is a very good table from Pharmacology of Tribathy, and it is giving you a very good comprehensive overview of various etiologies of cough and the treatment approaches. Just for instance, if it's a very important point here, that if the cough is caused by ACE inhibitors, and you might remember this from your previous pharmacology, there's ACE inhibitors which are used as antihypertensives. They are very notorious in causing dry cough. So if they cause dry cough, what do you do? Now, if a patient comes to you and he says that he has been coughing like crazy for the last 2 to 3 weeks, and if you take his drug history, he tells you that he was prescribed an antihypertensive, and you just come to know that this was lisinopril or perindopril, what will you do? You're not going to prescribe a cough syrup. Rather, you are just going to change his medicine to another safer or another antihypertensive which does not cause cough. Similarly, if a patient comes to you with a history of asthma, or he says that he keeps on having asthmatic attacks, and you know asthma is characterized, probably you don't know, but you will inshallah know soon, that asthma is characterized by severe bronchoconstriction and cough and wheeze. So that type of cough again is not treated with any cough syrup. It is not treated with any antitussive or any expectorant. Rather, in asthma, you might have learned this already in ANS pharmacology, that you give beta 2 agonists, you give bronchodilators for asthmatic cough. So you don't give cough syrups for most of the etiologies of cough. But in certain cases, you have to prescribe a cough suppressant or a cough medicine. Now that brings us to the classification of various cough medicines that are available in market. So remember, the market is replete with a large number of cough formulations, and generally there are an assortment of various drug groups, and those various drug groups are classified here. The first one would be pharyngeal demulcents, then we have expectorants in the list, then we have mucolytics, then antitussives, and then last in the list is your adjuvant antitussives. Now let's have a closer look at all these drug groups. So for what are pharyngeal demulcents? You might remember that demulcent is not a new word for you. Anything that has a soothing property is called a demulcent. So demulcents like lozenges, which are in your strepsils, are used as a cough medicine, are used as a cough remedy. Then next in the list is expectorants, which are also known as mucokinetics and also known as bronchial secretion enhancers. And we'll be talking about their mode of action. But one of the most important expectorant that is currently in use is this one, which is highlighted in bold, is guaifenesin. Then number 3 is mucolytics. Mucolytics, as the name indicates, lytics, that is, it is going to break down mucus into some thinner strands. That is why this group is also called as sputum thinners. The important ones, again, here are mentioned in bold: bromhexine, androxol, acetylcysteine, and carbocysteine. Now, the 4th group, which is the cough center suppressant. So in the previous slide, none of those 3 groups were trying to suppress the central cough centers in the medulla. The cough centers in the medulla were not being suppressed. They were trying to, those groups would treat cough by different mode of action, Here, however, antitussives are going to suppress the cough centers, and they are also going to suppress the transmission of impulses from the periphery. So those from this group, which are going to have an effect in the CNS, in the medulla, are called central antitussives, and those which are going to have the effect on the peripheral nerve transmission are called peripheral antitussives. Benzonatate and pentoxdiazine are 2 important examples. And just moving on to the last group. This is called adjuvant because the drugs that are mentioned here, and you might have noticed that these drugs again are not new to you. You have discussed them, you have read about these drugs, about most of these drugs in your previous lectures. So these drugs are not primarily cough medicines. However, they have added properties or added pharmacological properties to control cough or to treat cough or to manage cough. That is why they are classified here as adjuvant antitussives. So the important thing about this group is that they are not per se cough medicines, but they have this added advantage or an off-label use of being cough suppressants or antitussives. That is why you are classifying bronchodilators, antihistamines, the H1 antihistamines, and decongestants like ephedrine and pseudoephedrine here as cough medicines, although they are not cough medicines, but they have the ability to suppress cough. Now that you have classified them, and now that you know that what types of coughs should be suppressed and what types of coughs should be left as such, now we'll be talking about all these 5 groups that we have just classified in some detail, not a lot of detail, but you need to know their mode of action, their mode of action, how do you differentiate one group from the other, and what are the clinical indications where you would prefer one group over the other. Talking about the first group, which is demulcents, it's very simple to understand. It's just anything that is going to have a very localized effect on your pharynx or your upper airways is called a demulcent. It is anything which has a soothing property. The classic example would be strepsils. Now, this is a bit tricky, expectorants. Expectorants are also known as mucokinetics, and what are they doing? As the name indicates, expectorants, they are going to enhance the phenomenon of expectoration or the phenomenon of expulsion of sputum, especially if the sputum is very viscous and if it is kind of inspissated in the tracheobronchial tree. These drugs help to cough out or just expel that sputum. So that is why they are called expectorants. And how do these drugs cause expectoration or removal of the mucus? This first line is describing their main mode of action. These expectorants or this drug group increases the volume or the fluidity of the sputum and decrease the viscosity of the sputum. So when the sputum is going to be in larger volume and it is going to be less viscous, it will be naturally easy for a person to cough it out. So viscosity is generally decreased by these 4 principles. Out of these, the first 3 are actually describing the mode of action by which expectorants decrease the viscosity of sputum. Hydration is if you give water, if you are like taking steam inhalation, this steam inhalation decreases the viscosity of sputum, increases the fluidity of sputum. Then if you alter the pH or if you introduce any such drug which is going to have what do you say, hyperosmolar with a concentration, if you introduce such drug into the tracheobronchial tree, if its osmolarity is higher than that of your body, naturally a hyperosmolar solution, it always induces or it always attacks more fluid. So if there is going to be any drug in your tracheobronchial tree which is hyperosmolar, naturally this is going to increase the amount of sputum production. So if there is going to be more sputum, it is going to be more fluid and it is going to be less viscous. So this is how, by these 3 mode of actions, this expectorants increase the fluidity and decrease the viscosity of sputum. So some important drugs that are in this drug group are sodium and potassium citrate. And as you can see that this increases the secretion by salt action because it is hyperosmolar. It is going to increase the production of sputum. Then there is potassium iodide. So some of these, please remember that some of the expectorants cause and have a direct effect on the tracheobronchial tree. Sometimes they just directly stimulate the tracheobronchial glands to produce more sputum, and sometimes, just as you would see in this slide, that there are some expectorants like ammonium salts which do not have a direct effect on your tracheobronchial tree, but they have a direct effect or a direct effect on the gastric mucosa or on the respiratory mucosa. So they do not have a direct effect on your tracheobronchial glands, but they have a direct effect on the gastric mucosa or the respiratory mucosa, as a result of which there is going to be a reflex increase in the respiratory secretion. So this is another way by which expectorants work and increase the respiratory secretions. So you know that there is a salt action, then there is a reflex increase of respiratory secretions. And now then we will now be talking about guaifenesin, which again is an expectorant, and it again enhances bronchial secretion, and it also causes this particular drug, it causes increased tracheobronchial secretions by directly stimulating the tracheobronchial glands. So it is a drug which is actually being excreted by the tracheobronchial tree. When it is excreted, it just irritates the whole tree and it stimulates the glands, and naturally when the glands are stimulated, there is going to be increased production of mucus. So this guaifenesin is perhaps now the only member of this group of expectorants which is in wide clinical use. Others are not very commonly used now. So expectorants, you must remember the mode of action, that how do they increase the viscosity, decrease the viscosity and increase the volume, and which are the common and more widely used examples. Guaifenesin is one of them. Now, moving on to the next drug group, which is mucolytics. Mucolytics, again, are going to enhance the bronchial secretion, and they're going to help a person to cough out those secretions, but in a different way. How is the way different? In my previous slides, there was this this thing mentioned about how by 4 different ways the viscosity of sputum can be decreased. So I told you that the first 3 mode of action are the mode of actions of expectorants, but the last one here is the mode of action of mucolytics. So all the mucolytics, it be acetylcysteine, it be bromhexine, all the mucolytics, what they do is that they break down, they chemically break down or degrade the bonds in the mucopolysaccharides. When the bonds are broken, naturally the mucus is thinner. So this is how they liquefy the viscous bronchial secretions and help in coughing them out. Some common examples are bromhexine and Embroxol. And here is, and there is this mode of action, that they all of the mucolytics, they depolymerize the mucopolysaccharides, and the tenacious sputum is then just broken down. And this is done either directly by the mucolytics, and sometimes it is done indirectly by liberation of lysosomal enzymes of your body. So these drugs are particularly useful in patients of acute or chronic bronchitis when the mucus plugs are there, but they are kind of inspissated. So they have to be broken down and liquefied to help a person cough them out. The other drugs which are in this group, the mucolytic group, is acetylcysteine. Again, the mode of action is same, just opening the bonds of the proteins in the mucus. And the important thing to remember is that acetylcysteine, when used for cough medicines, is always used, it is always administered directly into the respiratory tract. It be used by nebulization or directly instilled through tracheostomy tube, but it is not used orally. And here I would like you to please reflect upon this question, that you might have heard of this drug acetylcysteine earlier as well, and it was used orally for an indication. Please try to recall what was that oral indication of acetylcysteine, and you do it as your homework, please. Then there's carbocysteine, again the same mode of action as acetylcysteine. So we have so far discussed 3 drug groups. The first one was demulcents, then we talked about expectorants, and then we talked about mucolytics. And in mucolytics, the important 4 drugs were carbocysteine, acetylcysteine, and bromhexine and Embroxol. So just giving you a more clear concept of, so that you are able to differentiate between expectorants and mucolytics. Both of them are actually enabling a person to cough out the viscous mucoid secretions, but both of them are doing it in a different way. One is just increasing the volume and is just stimulating the body, the tracheobronchial tree, to produce more and more of sputum, so that the volume is more and therefore the viscosity is less. But mucolytics are, on the other hand, are just breaking down the chemical bonds between the in the mucopolysaccharides. So they are doing it more chemically. On the other hand, expectorants have more of a physical action and mucolytics have more of a chemical action. So this differentiation, this difference should be very much clear in your minds. Now coming to the fourth group, which is that of antitussives. Antitussives means cough suppressants, literally means any group that is going to suppress your cough. This cough can be suppressed either centrally by giving a drug which has its action on the cough center, or it can be done peripherally by giving a drug which actually reduces the these impulses to be transmitted to the CNS. But important thing about antitussives is that these antitussives, they should not be given unless the cough is very debilitating, or it is affecting a person's life or sleep, or is hazardous because it is aggravating certain health conditions. These antitussives should not be prescribed. You may prescribe something from the adjuvant medicines or expectorants or mucolytics, but directly suppressing the cough centers or drugs with CNS effects should not be prescribed as the first line cough medicines. So in cough medicines, when we classified the cough medicines, we mentioned opioids in the list. So you have already covered opioids pharmacology in CNS, and you might remember that opioids had a pharmacological effect of suppressing cough. So suppression of cough is actually a well-recognized effect of opioids. Codeine is a prototype drug for antitussive action. Important thing to remember is that cough suppression by opioids occurs at a lower dose than that needed for analgesia. So, you know, the opioids, you must know that opioids are primarily used for analgesic effects, but they have so many other clinical uses as well. And one of those uses is cough suppression. So cough suppression, another important thing that you need to make note of is that cough suppression by opioids, when you suppress the cough centers, there is not going to be any cough, and when there is not going to be any cough, then naturally the secretions are going to be accumulated, and this can lead to obstruction, and it can lead to atelectasis, which is why these opioids or antitussives should not be generally used. Among the central antitussives, codeine, which is an opioid, but very much similar to morphine, is the prototype drug. It is a prototype standard antitussive, and because all other antitussives, the newer antitussives, are compared with it. And as I've already mentioned, that the antitussive dose is lower than the dose that is required for analgesia. And regarding its mode of action, some people, it is postulated that maybe the mode of action is independent of the neuroreceptors, but because the antitussive action is also blocked by naloxone, you might know that this is the opioid receptor antagonist because it blocks the antitussive action. So again, there is this postulation as well, that probably the antitussive action is also exerted through opioid receptors. However, the exact mode of action is not very well known. For some important points, whenever we talk of opioids, we always talk about abuse liability because they generally have a very high abuse liability. Codeine and some of the drugs from this group which are used as antitussives generally have a low abuse liability, but and they're generally safe in moderate therapeutic doses, but in higher doses they can cause respiratory depression and even CNS depression. And you must know the contraindications to these central antitussives. They must never be used in asthmatics and with patients with a respiratory reserve, diminished respiratory reserve, because naturally if the cough is suppressed, there is going to be accumulation of secretion. And also in children, because of these adverse effects that they can cause respiratory and CNS depression. Folcodeine is very much like codeine, but has a longer duration of action and is safer than codeine. Then another central antitussive is noscapine, very much effective, very much in use. Codeine and folcodeine से ज़्यादा अब ये use हो रही है because it has no other analgesic and narcotic effects, because we don't need these effects from an antitussive drug. But एक जो problem ये कर सकती है that it can cause histamine release and bronchoconstriction in asthmatics. So asthmatics में you should be careful, आप कोई भी central antitussive asthmatics में नहीं देते. Then another antitussive, central antitussive is dextromethorphan. इसका भी नाम आप have already heard about this. Again, mode of action वही है that it has going to suppress the center, the cough center, and via the mu receptors. But some important points about dextromethorphan are these: that it is an NMDA receptor antagonist as well, one of its metabolites. And you might remember that anything that has effects on NMDA receptors, or they block the NMDA receptors, they have certain hallucinating properties. So remember when I taught you CNS, CNS stimulants, I talked about dextromethorphan over there, that because of this NMDA receptor antagonist property, this particular drug, dextromethorphan, can be abused. So this drug, out of this drug group of central antitussives, has a high abuse liability. It can cause CNS depression as well as dissociative hallucination in higher doses. So this drug is often misused, and because it is available easily over the counter, so its addiction or its abuse liability is really high. People can easily misuse this drug. And another important thing that you must remember about this drug is that it is generally contraindicated in children, because this drug, along with other, because generally, you know, cough syrups are a cocktail of so many drugs, which कहीं से आप इसमें डाल देते हैं. एक expectorant भी होता है, mucolytic भी होता है, antitussive भी होता है. So there are just 3-4 drugs combined together in one cough syrup. So all of them generally have some CNS depressant properties or CNS stimulant properties. So in children, because they are a vulnerable age group, so they generally cannot tolerate those CNS stimulant or CNS stimulant or CNS depressant effects. So children are generally more vulnerable to the adverse effects of central antitussives, especially dextromethorphan. So please keep this thing in mind, that generally the cough and cold medicines or cough syrups should not be prescribed to younger children, especially those cough and cold medicines which have dextromethorphan as an ingredient. Now, talking about the peripheral antitussives, so far we have talked about 4 drugs which were having an effect in the CNS. Those drugs were codeine, folcodeine, noscapine, and dextromethorphan. Now we will be talking about peripheral antitussives, and benzonatate is one drug. And the important thing about this is that it has an anesthetic action very much similar to that of benzocaine, which is actually a local anesthetic. So local anesthetic effect की वजह से the tussle impulses will not be transmitted, and hence it is going to exert a peripheral antitussive effect. And then another peripheral antitussive is phenoxdiazine. Again, this also has peripheral effects, and it is also going to reduce the tussle impulses from the lungs. This one is administered orally, and the important thing to remember is that all the peripheral antitussives are safer than central antitussives. Now, coming to the last group, that is that of bronchodilators. In this group, we'll be talking about bronchodilators, we'll be talking about antihistamines, and we'll be talking about the decongestants. So when we talk about bronchodilators, you know that some types of coughs are caused by bronchospasm or bronchoconstriction. Whenever you have bronchoconstriction, you can have a spasm of, you can have a cough episode. So what do? All the bronchodilators, you might just recall any bronchodilator like a beta-2 agonist like salbutamol, or which is called Ventolin. What do? They, by causing bronchodilation, when there is going to be bronchodilation, they will increase the surface velocity of airflow. So the bronchodilators are going to cause bronchodilation, and there is going to be increased surface velocity of airflow, and this is going to make the cough more effective. And that is why they are very helpful in asthmatic coughs, and in coughs that are associated with bronchospasm. So these bronchodilators should be used as a component of cough medicines, or they should be used to relieve cough only when an element of bronchoconstriction is present. Otherwise, they are of no use. Some common examples are acetylene and aminophylline. These are actually, both of them belong to a theophylline derivative, theophylline group. And you have not read about this group as yet, because this is a group that you'll be learning about in your lecture on asthma. But for now, you just remember that these are acetylene and aminophylline, again, are very important ingredients of so many cough syrups like Hydralin and Aciphyl. And they, by just blocking the adenosine receptors, they have this direct bronchodilator effect. Another important thing about their being used in cough medicines is that they have this ability to offset sleep. Because you might remember that caffeine, when I taught CNS stimulant to you, one of the important group mentioned in that lecture was that of caffeine. Caffeine is the CNS stimulant, and it is a CNS stimulant because it is an adenosine receptor antagonist. So anything that blocks the effects of adenosine can cause sleeplessness. So when you combine these drugs like acetylene and aminophylline in the cough medicines, they are going to counter the drowsiness which is caused by certain drugs in the cough medicines like diphenhydramine. Diphenhydramine is an H1 blocker, and it causes a lot of drowsiness. So if there is diphenhydramine in a cough syrup, and there is acetylene in that as well, so the drowsiness is going to be countered, and there is going to be no prominent effect on a person's sleep. So this is another advantage of adding these drugs in a cough syrup. Besides the main advantage of there being a bronchodilator, they also can prevent effects of sleep by certain drugs. Then there's Wibutylene, which is a beta-2 agonist. You might have heard of this. You might have seen this drug in your homes or in hospitals or in pharmacies. This is Britanil. It has basically two ingredients, Wibutylene. It has basically one ingredient, I think, Wibutylene, and it is very much, so where do you think you're going to prescribe such cough syrup or such bronchodilator? Of course, you're going to prescribe it in a patient of asthma. You're not going to prescribe this medicine to all patients coming to you coughing. So the second adjuvant group, adjuvant antitussive. First one was bronchodilators, and the second one is antihistamines. And amongst antihistamines, it is first generation only, which is used as a cough remedy. And this and their antitussive action is probably exerted through their effects on the muscarinic receptors as well. You might remember that H1 receptors are not just blocking the H1 receptors, but they are also blocking some other receptors in your body like alpha-1 and M3. So by blocking M3 receptors, they decrease the bronchial secretions, and hence they can manage cough in a better way. So this is again the same thing that I've just mentioned, that probably they relieve cough due to their anticholinergic actions, and they don't have any other property as such. And generally, they are used in respiratory allergic states. So if cough and cold, या general common cold वाला patient आ रहा है, जिसके साथ में rhinitis भी है, साथ में cough भी है, so antihistamines can be a very good option for such patients. Then the last from the adjuvant groups is sympathomimetics. Ephedrine, pseudoephedrine, and phenylephrine. Again, आपने इनको पढ़ा हुआ है. These are all alpha agonists, and by causing vasoconstriction, ये भी बहुत बेहतर feel करा सकते हैं a person who is coughing. The aromatic chest rub is just a herbal remedy, and that's it. Please try to answer this one. The correct answer to this one is, I think, D. And please try to find out the correct, try to identify these drugs and their drug groups. Please try to find out where does this diphenhydramine belong to, and ammonium chloride belongs to which group. And this is again a part of your homework. Thank you very much.